this evening Professor Murray Esler. I'll just like to introduce Murray formally. He's a clinical cardiologist and medical scientist. He's Senior Director at the Baker IDI Heart and Diabetes Institute, Associate Director of the Heart Centre at the Alfred Hospital, and Professor of Medicine at Monash University. Professor Esler leads the Baker Institute's research into the relationship between the brain and heart health. His chief research interests are the causes and treatment of high blood pressure and heart failure, the effects of stress on the cardiovascular system, and neurotransmitters of the human brain. His research on the sympathetic nerves of the kidneys in essential hypertension provided the theoretical basis for the development of a revolutionary treatment of high blood pressure, involving silencing these nerves with a radio wave emitting catheter placed in the kidney arteries. This treatment, called renal sympathetic denervation, is now used clinically in Australia, Europe and the United States for severe drug-resistant hypertension. Professor Esler has over 350 publications in refereed journals and a long list of national and international medals and awards, including awards from the American Heart Association and the European Society of Hypertension. Here in Australia, he's received several distinguished awards, including a Centenary Medal in 2003 and an Order of Australia in 2007. So it is with our great pleasure that we welcome you here tonight, Professor Esler. Thank you so much.
Thank you very much for that very fulsome welcome. Reminds me a little of introductions in America, where the introduction's always longer than the talk. I'm a clinical cardiologist. I still work as a cardiologist. So what am I doing with a topic like this? As a young man, I did a neuroscience PhD in ANU, and my wife of 44 years is a psychiatrist, so that kind of explains some of this. Rosemary Swartz, some of you may know Rosemary. My voice is not very strong, so tell me if you have trouble hearing what I say. Now, this is a field where for 2 centuries we only had anecdotes, and there were good anecdotes, such as this one, John Hunter, who, a famous surgeon who had coronary artery disease and a very bad temper. And at a stormy meeting of his hospital board, he grasped his chest, excused himself and dropped dead in the corridor, really proving this adage that he'd said earlier. But we only had anecdotes, and there was a lot of scepticism, and this is typical of a few meetings I was at where the chairman actually said this. Hard to imagine, that's some time ago, 30 years ago, but that was actually said. But that all changed with this particular observation, a study in Los Angeles on the North Ridge earthquake. And it was a study of sudden death, and on the day of the quake, I knew I shouldn't have used this thing. On the day of the quake, this is what happened, a huge increase in cardiac arrest. Many of these people had silent coronary disease on autopsy, but nevertheless they were killed by the quake through psychological mechanisms. Now, that was not the first study of this type. The first was actually an earthquake in Athens, and then Scud missiles into Israel did the same in terms of triggering heart attacks. And of course, Greece now has another unnatural disaster, and their financial disaster, no doubt, is killing people through this sort of mechanism. The Twin Towers disaster was the same thing. By this time, a lot of people had continuous ECG monitoring and cardiac defibrillators because they had nasty arrhythmias. And in the 3 months following this event, there was about a 3-fold increase in the discharge rate in these arrhythmias. In other words, these are patients who would have died suddenly except for their defibrillator. And this was not just in New York, it was in various cities throughout USA. So the idea of triggering of heart attacks is now widely accepted, psychological triggering. And this is another example, a little less related to natural disaster. Anyone know what that is? Any soccer fans here? This is the flag logo of the German soccer team, and people have a bad habit of dropping dead at soccer matches, as I'll show you. And this was well documented in the 2006 World Cup. And football fans at World Cups are very enthusiastic and partisan, and they put them in separate national cage, and this is the German cage at one particular event. And this is what the study showed. This was a study in Munich, and the World Cup was in Munich, and it was acute cardiac hospital admissions or sudden death in German nationals during the 40 days or so of the World Cup. And the baseline is what happened for 2 earlier years, about 20 events, and then there were numbered peaks related to particular days when Germany was playing. And there were 3 preliminary matches to see if you got into the semi-final, and it was obviously very bad for German heart health. Germany actually won the first 2 and they were through to the semi-final, so there was less emotional heat in game 3. Then it was the semi-finals, and the first semi-final they got a couple of early goals, and it reflected in how they felt about things. But then the final match, to see if they got into the semi-final, was a real nail-biter, but they did get through. And then they had the semi-final, which was a penalty shootout, and they were on a knife edge, and unfortunately people dropped like flies watching that match. But they lost it, which was good for them. So what happens next is the semi-final losers play off to see who'll be who'll be third and who'll be fourth, and who cares? Who cares? And this is what happened. The Germans had no investment in that whatsoever. And then this is the final, French versus Italy, and they weren't too interested in that either. So in a way, it's a plausible dose-response curve of acute mental stress versus sudden cardiac events. Now, what I want to talk about for a moment is some of the things we can measure in stress that are pertinent to what I've been talking about. And the first of these, we can actually study the human sympathetic nervous system pretty well. We can, with microelectrodes through the skin, measure sympathetic nerve traffic, and we can measure the rate of release of the sympathetic nerve transmitter from internal organs. This is what nerve recording looks like through the skin with a very narrow needle. You can impale a sympathetic nerve and record its firing activity. For internal organs, it's a little more complicated. You need to drain blood from the veins of internal organs, such as the heart and the kidney. But as a cardiologist, my ethics committee let me get away with stuff like that because it's a piece of cake to a lot of the stuff you do, putting stents in people and the like. And we can do that safely, and we can apply these methods. And what we find is that in acute stress responses, particularly in relation to heart events, it really is the sympathetic nervous system and adrenaline that causes the trouble more than cortisol. Hans Selye was a famous man in stress research. His work was on cortisol. Very important work, but not important in this context. So what happens when a heart attack or sudden death is triggered? This has been well documented, and there are one of four things that can happen. In an acute stress response, when your blood pressure suddenly peaks, you can get rupture of an atherosclerotic plaque and subsequent thrombosis on it. The second thing that can happen is if your coronary arteries are narrowed, very high sympathetic tone can cause lethal arrhythmias. The third thing is that high levels of adrenaline and sympathetic nervous activation causes platelet activation, contributing to thrombosis. And as I'll show you in an angiogram picture a little later, under stress people can get spasm of the coronary artery. So they're the mechanisms of triggering of these events. Now what I'm going to talk about, this is sort of broad brush of psychogenic cardiovascular disease, triggers such as I've mentioned, panic disorder, which is more of the same in a sense, major depressive illness and its relation to heart disease. Similarly for schizophrenia, the downside of psychotropic drugs in terms of cardiac health, and then chronic mental stress, and I'll particularly look at chronic mental stress and its relation to high blood pressure. Now I did mention, I did have on a slide something called Takotsubo cardiomyopathy, which is an acute stress heart failure. And I'll tell you more about that. This is a dye picture of someone's left ventricle, and at the end of the filling phase, diastole, the ventricle is rounded and full. But this is abnormal. During pumping, systole, the ventricle usually narrows to a fine point, but in this acute heart failure, it's expanded in a bulbous way. So it's apical ballooning of the heart. Now this is usually caused by very severe acute mental stress, such as a bereavement, sudden unexpected bereavement. But stress is symbolic and differs for everyone, and at a meeting I organised, one of the speakers described one of his patients who got Takotsubo cardiomyopathy. It was a very stylish, well-dressed woman who went on a camping holiday, upmarket camping holiday, and she had new outfits, and she was in the tent dyeing her hair, and a sudden windstorm upset the tent, and she spilled dye all over her new hair, and she got Takotsubo cardiomyopathy. And of course all the men in the audience laughed at this and thought it was amusing. And my wife, the psychiatrist, leaned over and said, that would have given me Takotsubo. So, usually a bereavement, unexpected bereavement. Why is it called that? Well, the Japanese name for an octopus pot is the Takotsubo, and the first description of this disorder was by Japanese heart doctors who thought the picture of the heart on the dye angiogram actually looked like the bulbous end of an octopus pot. We still don't know a lot about this, other than what I've told you. Severe stress is a trigger, thought to be caused in some uncertain way by huge levels of adrenaline, up to 100-fold increase, so truly huge, and very marked activation of the cardiac sympathetic nerves. But there are puzzles. It's commonest in older women. We don't know why. What are the vulnerabilities? Again, not known. And this is unusual. These patients usually survive. They might have a rocky course for a week or two, but unlike other forms of acute heart failure, such as with a myocardial infarction, survival is typical. Now, in Victoria, we had an epidemic of this 5 years ago, triggered by the bushfires. In my own hospital, in Monash Medical Centre, and when you see pictures like this, it's easy to imagine how that might have happened. And it occurred also in male and female CFA workers, but also civilians. So let's move on to panic disorder. I've looked after panickers for all my professional life, and the last thing they want to hear is actually there might be something wrong with their heart. And it was about 25 years ago that the epidemiological evidence emerged that panic disorder can have adverse effects on the heart. Not common, but certainly well described. What happens in a panic attack? I mentioned we can measure sympathetic nerve firing. This is from a patient who in laboratory, as we're doing a clinical research study, actually had a panic attack. And these bursts are huge bursts of sympathetic nerve activity as we could record it before, during and after the panic attack. So that's no big surprise, but that's what happens. And this is typical of the patients I've seen over the years. This was a 34-year-old woman, and there is probably about a 4-to-1 gender imbalance in the prevalence of panic disorder. She attended a hospital emergency room, it was the Alfred Hospital, with multiple episodes of severe chest pain and cardiograph changes, which I'll show you in a moment. She hadn't had a heart attack, the enzyme tests for that were normal, and her cardiograph on a good day was normal. And the penny didn't drop, but she was noticed to be very fearful on her last attendance, and then they got me involved. And then she had a coronary angiogram to be sure about things. And this, what happened in a panic attack, the ST segment is depressed, typical of ischemia, whereas on a good day that was quite normal. The angiogram, though, was normal. There was no coronary disease. This was not done during a panic attack, and it was normal, and she was treated, and I'll talk about the treatment shortly. But we've actually caught a few patients with panic disorder and chest pain when they've had an angiogram and depicted coronary artery spasm. This was a 50-year-old barrister who had recurrent panic attacks and angina in cases in court. And we thought we really did need to look at her coronary arteries, and she had a panic attack on the cardiac catheter table, and she had demonstrable spasm in the left anterior descending, which was partially reversed with a glycerol trinitrate on the table. So coronary spasm, I believe, occurs very infrequently, but that is the basis for severe anginal chest pain. Now, I'll just tell you a little more about the biology of this, something that was discovered by one of my PhD students, Marley Zelvarenga, and what she found was that the normal mechanisms the nerves have to switch off is to take the transmitter back into the nerve, so the noradrenaline reuptake terminates the signal. And what Marley's found, and I won't go too much into the details, she found this process was abnormal, defective in panickers. And the main way we measure this, we infuse a tracer dose of tritiated radiolabeled noradrenaline and look at its uptake by the nerves of the heart, and also a metabolite that the nerves make. And it was very clear that panickers have this unexplained problem. So there's no doubt, I believe, that this reuptake defect would actually increase the effect of this neural signal, and it's probably why the sympathetic activation in panic can cause, in some people, coronary spasm. So how do I treat somebody with panic disorder who I think is at cardiac risk? Most of them are not at cardiac risk. Of course, it's common to have tachycardia, discomfort in the heart, but occasional patients have crushing chest pain that really is angina, and they're the ones I take seriously. Now, if someone has angina in another context, there are stress tests you can apply which usually make the heart work more. And if there's fixed narrowing the coronary artery and you make the heart work more, such as on a treadmill, doing exercise, you can get changes that are diagnostic. But the conventional stress tests are no good here. So you make a clinical diagnosis. If you're lucky, you might catch it in an angiogram. You obviously then treat the panic as well as you can. But then there are two special things. One is calcium channel blockers, a class of vasoactive drugs, can reverse coronary spasm, and they're very effective in panickers who have anginal pain, and I've followed patients for 20 years. And I also put them on low-dose aspirin, because if you have coronary spasm and your coronary artery is narrowed, you're at risk of getting a clot on it. So the treatment is the usual, plus calcium channel blockers and low-dose aspirin. We've done some research on the brain neurotrans mechanisms of panic disorder, looking in particular at release of serotonin. And the way we can do this relies on the production of this serotonin metabolite, 5-hydroxyindole acetic acid, which we can measure. And I mentioned my Liberal Ethics Committee, who lets me put catheters, go north rather than south into the heart, go north into the jugular veins and take samples. And when we do this, what we find was totally contrary to what was expected. It's always been said that the biological mechanism of a panic attack involves the locus coeruleus, the brain area that releases noradrenaline, but we found this to be totally normal in panickers. But serotonin release was at a very, very high level. This is totally contrary to what had been thought. The general view is in panic disorder you have, in essence, a serotonin deficiency, and the serotonin reuptake blockers fix that up. But that's not what we found at all. And what we did find was the severity of panic severity, which Marley's Alvarenga quantified, was strongly related to this level of turnover of serotonin. Now, there are brain neuronal systems in the raphe that release serotonin, and they're well known in animals to be related to different types of anxiety. So I think that's what's going on. And in a study involving dosing with SSRIs and also independently with CBT, we found that both of these therapies reduced this abnormality in serotonin turnover. So this is not caught on, and nobody believes it except us, but the methods were very direct, and I think this is probably how the truth is. Now a word on depressive illness. The discovery of the link between depression and heart disease is a very interesting story. It was discovered by Nancy Fraser Smith, who had a physician as a husband who was given a good job in McMaster University, and she, being an old-fashioned wife, went there even though she didn't have a job at first, but then she got a job in the same department, and she did provided the very first documentation that depressive illness is an antecedent to coronary artery disease and heart attacks. And that's been confirmed in many studies since. We're still at a loss to know how this happens. I just should mention perhaps that there was an Australian paper which has been very influential, a position statement through the Heart Foundation, with diverse authorships, psychiatrists, psychologists, cardiologists, which is typical of this field, showing that depressive illness and social isolation in particular were antecedents and probably causes. Our own biological research on this has shown something rather odd, and that is when we look at the level of sympathetic activity in depressive illness, it's this scale, this is just at rest. In about a third of depressives, they have extremely high sympathetic activity at the level we see in heart failure, and that level in heart failure is lethal, and we now block it with beta blockers. So that's really the question that's unanswered. Should we be using preventive beta blockers in depressive illness, particularly in patients with long-standing, persistent drug-resistant depressive illness? And there's no trial at the moment. That's just a theoretical argument based on the fact that sympathetic tone in depression in a third of people is so very high, as high as you get in heart failure, where beta blockers are life-saving. I'll change tack for the moment and talk about cardiovascular safety of psychotropic drugs. And of course the big problem here is many psychotropic drugs put on a tremendous amount of weight in people, put their blood pressure up, can cause diabetes. And many of you would be familiar with patients putting on 20 kilograms in 6 months when their depression or psychosis is treated. And this is a particular concern in schizophrenic patients where some of the antipsychotic drugs, novel antipsychotics, they need for symptom control and well-being, but it has a terrible effect on their body weight and their blood lipids. And that's magnified because, of course, in schizophrenia, they often have bad risk factors anyway, and so many of them smoke. So I think the message here is, and it hasn't got out to GPs yet, is that when you look at SSRIs and novel antipsychotics, they differ in the capacity to have this bad effect. For example, Cipramil is much less likely to do it than Arapax, and Seroquel is much less likely to do it than olanzapine, and that's an important message for GPs and cardiologists. Now I want to move on to something else, and that's the issue of whether chronic mental stress causes illness, and there's evidence it causes coronary artery disease, which I won't cover today, but I'll talk about mental stress and its relation to high blood pressure. And again, there are polls of opinion. This is another committee I sat on, and this was the chair of this expert opinion. For him, we get it easy these days, and whereas another contemporary opinion is we live in very stressful times, mainly in terms of time urgency. And the chap who wrote this, Stephen Klein, had pictures of suburban life 100 years ago, early motion pictures showing that people ambled along the street and chatted to everybody they pass, and totally different now. And in Klein's view, we're very much in the group of the internet and immediacy. So he sees time stress as critical in the stresses of the modern day. Obviously there are many others. This is a familiar model, and then I'll apply it to hypertension. Very familiar model that for chronic mental stress to cause illness, there's continuation of an aversive stimulus which has psychological and physiological consequences, which can be, in certain circumstances, perpetuated to the illness. Now, genetic predisposition may augment this, whereas coping strategies and social supports can actually have a positive influence and minimise that. And in the context of hypertension, it would be various types of stress, and there's very explicit work on types of stress in the workplace, causes sympathetic activation and perpetuated into causing hypertension. And I'll show some evidence for this using biological markers in hypertension, stress biomarkers. The traditional approach, of course, has been to do epidemiology on high-stress groups, such as air traffic controllers. But what I'll show you is a little different. Now, the first bit of evidence is this, and that when you study people with high blood pressure, you find more often than not very high sympathetic tone in their heart and their kidneys. So that's not proof that they're stress exposed, but it's collateral evidence. Now, a second thing we find is that sympathetic nerves release the adrenal stress hormone, adrenaline, which they never do in health, but it's very common in hypertension, and in this particular study, the sympathetic nerves of the heart released quite a lot of adrenaline in people with high blood pressure, but not in healthy people. This has been well shown to happen in stress models in animal research. So we wanted to look at that a little more, and we wanted to look at the enzyme that makes adrenaline. Is it actually expressed in sympathetic nerves? It shouldn't be. And this is actually the director of the Baker Institute who participated in this work doing a vein biopsy. And we looked at vein biopsies as a ethically acceptable way of looking at sympathetic nerves. Veins are full of sympathetic nerves. And we had ways with Western blot, a form of analysis, of looking at the various enzymes. The one we're interested in here, the methyltransferase, actually makes adrenaline if it's present. Well, it's not there in healthy people. In healthy people there was no PNMT. In this pilot study it was in 2 of 3 people with panic disorder, and it was in pretty much all of the 5 essential hypertensives we studied. So there's a range of biological evidence that stress is a mediator of hypertension, and there was a medical review council set up to see if stress caused hypertension, particularly in the workplace. And this was the finding. Yes, stress does, and it's based on strong evidence of biological markers being present in hypertension patients, and this should have relevance to how the workplace is conducted. Now, this was very unpopular with the government of the day, the health minister of the day, and he responded, as you'd imagine. He reconvened a new committee, and they gave him the answer he wanted. So in the government gazette, myself and others said yes, and then subsequently in the government gazette it said no, stress doesn't cause hypertension. So that's of course what you have to deal with. Now when you look at how well stress reduction strategies lower blood pressure, they do, but they're not as effective as you might have thought from what I've just told you. And losing weight and physical exercise training is rather more effective than stress reduction. There's no answer for that other than in hypertension changes develop that are rather hard to reverse, particularly the small resistant blood vessels, the arterioles, thicken up when they're exposed to high blood pressure, and it's rather hard to reverse that. So that led me to take another tack, really, in our treatment of hypertension with this concept. We can't change the world, but as a cardiologist, can I change the kidney nerves? And the technique which I was involved in the development of is a one-off treatment where a catheter is put into kidney arteries and radio frequency energy is released. That's just radio waves of sufficient energy to silence the nerves. And the nerves go to the kidney close to the kidney artery, within reach of energy. So the technique was to go round and give a full spiral cover of energy to get all the nerves of passage as they went through. And now the first patient was treated in 2007. Something like 15,000 patients with drug resistance, severe hypertension have been treated, and many of my most severe patients have had this treatment, and most have done very well. The index patient was 200 on 130, and now she's about 140 on 80. So that's our experience. As I say, why did we think of this? Well, this is a graph of sympathetic nerve activity in hypertension, not in everybody, but often very high and 2 to 3 times normal. So that's the target. Now, when you let loose a device treatment like this, it gets into the wrong hands, and this is an assessment of how effective the actual denervation was in a group of people, and this includes some of our cardiologists. Zero denervation. So, and on average 40%, and we're aiming for more than that. So the procedure is useful but could be better, and there's better technology now, a new device which has just been developed. And these are the questions as we take this further. Should we be doing better than a 40% denervation? I'm sure we should. How can this be achieved with better device? But also we now know that the nerves converge on the renal artery as they get close to the kidney. So you have to get the catheter right out near the kidney and actually into the renal artery branches. That's where you can reach the nerves, and experimental studies show it works better there. So we've changed the kidney nerves. We couldn't change stress in the world. So this is a concept that's now common in what causes high blood pressure. Yes, there are obviously lifestyle things such as being overweight, being sedentary, and being exposed to stress. All of these actually activate the kidney nerves, which interact badly with high levels of dietary salt, which most of us eat, because the renal sympathetic nerves make the body retain more salt. And that's the mechanism of the hypertension, and you cut the Gordian knot with this treatment. So this is an ongoing area, watch your space, but a very technical approach to a difficult problem. Now in this field, of course, it's been very difficult to integrate these sort of concepts into mainstream cardiology, and it's very much work in progress. Although there has been a mindset change. For example, this was the American Heart Association. It was actually a multidisciplinary committee. Said that in patients with depressive illness, you should routinely test for depressive illness. Patients with coronary disease, you should routinely test for depressive illness. Cardiologists are not very good at diagnosing that, and tools have been introduced to try and make it easier for them. So that's the recommendation. I'm not sure how it's followed, of course. Now, on 3 occasions I organise a heart-mind congress in Tuscany, in a little town called Prato, which is a very non-stressful part of the world, except if you take your family. I was there with my extended family, all 10 of us, and I had to rent a little minibus for 10 people, and the GPS was in the Italian language, which was the start. And I don't know if you've been on those little hills in Tuscany. Driving a minibus around those corners was extremely stressful. But the point I'm going to make about this field attracts people from any discipline, and I'm sure represented in the audience tonight. Social workers, social epidemiologists, psychiatrists, general practitioners, cardiologists. It attracts a broad base of interest in research and clinical activity. But to be fair, we're still looking for the magic bullet in preventing psychogenic heart disease. Many of the mechanisms look apparent, but there are no statins for cardiac hypertension in psychogenic heart disease, so we're still searching. Thank you. I think